Professor Aguierre-Ghiso, thanks a lot to give us some minutes for a short interview. You just gave us a very fascinating keynote lecture on mechanism of early dissemination, dormancy, and metastasis in breast cancer models. On your completion slide, or last slide, you stated a change of our view of hallmarks of pathology and a paradigm shift with regards to metastasis and primary tumor growth. These are quite profound claims, but you not only stated it with your words, you enabled us to watch, really, and on video, dormant cells disseminating. Very fascinating. Could you just tell in a few words what you think will be the impact on research as well as on the clinical approach?
I think one of the short-term benefits or consequences, if you want, is that our results may start to explain some phenomena that has remained poorly understood. One of them is cancer of unknown primary, which is a quite frequent pathology. It's about 8 to 10% of all malignancies present with this diagnosis. 50% of them are adenocarcinomas. So these are cancers where there are metastases, but you could never find the primary tumor. So this tells us somehow that tumor cells can disseminate from a very early lesion without engaging in growth and then activating those growth programs after they arrive to the secondary organ. So in one of the experiments we show that these early lesions can behave as cancer of unknown primary, because when we injected them in the primary site, that they did not form a tumor, but we could then find metastases in secondary sites. So that's one aspect that I kind of like thinking about. The other is that in patients that are diagnosed with ductal carcinoma in situ, which although they do very well when treated for this lesion, about 3% of them develop metastasis. And half of them, of the ones that develop metastasis, develop these lesions without ever developing a recurrent invasive lesion. So these are thousands of women a year that die of metastasis of a tumor that was considered cured. So if we had ways of knowing if a DCIS lesion actually spawned dormant tumor cells that then can reactivate, because you could understand that we have now markers of what these cells look like in the primary site. This may be a population that may benefit from this work. So these are some of the ideas we're exploring. The third one, which I think is very important, is that we don't really understand metastasis. And if cells are leaving early and waiting for a long time to start to grow and evolving differently from the primary tumor, their genetic makeup may be different from what we see in the primary tumor, and their epigenetic makeup may be different. And when we treat based on information of a large invasive tumor, we may be missing some of this biology. So that, I think, is an important component. It forces us to not ignore these early disseminated cancer cells and focus more on the metastasis and its characteristics to improve treatment. The other is that if cells are dormant and they can sit there for a long time as early disseminated cancer cells, or even arriving from an invasive cancer, you can try to target those cells before they awaken and prevent metastasis. So these are some of the consequences of this work. But we're projecting it quite a long time in the future. We are really at the beginning of understanding what this process is. And finally, if we think that these cells are leaving early, even if they don't grow, they may actually condition target organs for later arriving cells to grow. So imagine a patient is not diagnosed for an in situ lesion. Cells disseminate, they arrive to target organs, they don't grow, but now they prepare, the soil for the later arriving cells from the invasive tumor. What if this mechanism is important? So we're doing experiments now, and we have some evidence that there is a cooperation between these early dormant cells and the later arriving cells. And all I can say is that it's very important that we understand this biology and we focus more on the metastasis and that biology to be able to prevent it and target it.
That's very impressive, and it sounds like you're opening a very important door to even better clinical outcomes afterwards. And it's not just...
That's exactly a very important point.
It's not just about breast cancer, it's on cancer in general, isn't it?
Yes. Yes.
Okay. And well, coming from the US is a long way. But I think to give this impressive keynote lecture is just the right place and the right audience. What's your impression on this first time joint venture of World Congress and European Society Congress?
I think this is a fantastic meeting. I attended some of the sessions this morning, and I think the pathology community serves an extremely important mission in the medical world, and I think that we need these meetings. We need to mix more pathologists with basic scientists. We need to create more multidisciplinary pathology that incorporates the development of new concepts and new technologies and new ways of detecting cells to improve the management of the disease. I think that we need to move from only looking at the primary tumor to better understanding residual disease. Because as you know, surgeons take care of most of these lesions. I mean, they're still our first line of defense, right? And then the oncologists take care of the later disease, usually when it's metastatic. So better understanding of residual disease, where are they coming from a pathology point of view? What is their biology will allow us to better target those cells and really prevent metastasis. If we could even change, increase by double or decrease by 50, increase by 50% the time to relapse, we would have a very impressive outcome change for the patients across different cancers.
Thank you very much.
You're welcome.